Hi, everyone. My name is Jeff Bell, and on behalf of all of us with the Education Outreach Department at McLean Hospital, I want to thank you for joining us from locations all around the world for today's online course designed to explore the realities of anxiety and OCD in children and teenagers. Whether you are a parent, an educator, a coach, or a healthcare professional, you have an important role to play in helping young people manage these mental health challenges. And today's presenters will provide practical strategies for doing so. Doctors Lisa Coyne and Jeff Szymanski, who will team up for our sessions today, beginning with a broad overview of anxiety and OCD in kids and teens. Lisa and Jeff, thank you both for being a part of this course. You each bring to today's discussion a wealth of experience working with kids and teens facing mental health challenges. Our goal is to tap into that collective wisdom, and we're going to be covering a lot of ground in this session. Before we get into some specific considerations and strategies, I'd like to ask the two of you to help us understand the bigger picture of anxiety and OCD in kids and teens. Lisa, let me start with you. What is the single most important message that you want to convey today to clinicians, parents, and other adults working with children facing these challenges?
I guess one of the most important messages are that these are extremely treatable disorders. We have an extremely strong evidence base in the psychology research literature that suggests that most children and teens will benefit from treatment with these. And if I might add one more thing, I would also, I think that an important point is that these are disorders of avoidance. So anxiety and the thoughts and feelings that come with OCD and anxiety are not necessarily the issue. The issue is what we do about them. And they lead to rigid patterns of avoidance-based behavior. And so treating those patterns of avoidance is a critical element of care.
Jeff, similar but different big picture question for you. What have you found to be some of the biggest misconceptions about recognizing and treating anxiety and OCD?
Well, I think people believe anxiety and other emotions are things they shouldn't have, right? Both Lisa and I have, and Farley have heard from clients coming in like, I don't want to have anxiety, right? So the goal isn't to get rid of anxiety. Anxiety actually is our friend. Anxiety is an alarm system, right? And I just want to underscore what Lisa said. Anxiety isn't the problem. It's what we do in response to it. When we avoid it and we treat something as dangerous when it may not be dangerous, we now have all kinds of anxiety in our life. But I think our goal really is to learn about how we work, learn about how our emotions work, really get curious about the experience of your emotion rather than, oh, this feels bad and I need to get rid of it. Right. So I think when we open up to that experience, we find out all kinds of cool things about ourselves.
Let's start with some definitions and kind of establish the vernacular of our conversation today. What exactly is anxiety and how does it differ from fear and stress by definition? Lisa?
So anxiety is a response. It's a physiological, cognitive, and emotional response to a perceived threat. Fear is a reaction that one has to a specific and actual danger. For example, if there is a snarling dog outside, I would feel very fearful. Anxiety also incorporates worry, right? Rumination and trying to, think a lot and exclusively about how do I solve this perceived threat. Anxiety isn't necessarily a problem unless dealing with it impairs your ability to get about in your everyday life and do the things that are important to you to build relationships that matter to you.
Jeff, what does typical anxiety look like in kids and teens?
It's going to vary quite a bit, right? And, it's always interesting too. Lisa and I do a lot of training of therapists, and one of the therapists' favorite phrases is just sit with that emotion. That's actually a really complicated skill. How do I know I'm anxious, right? So if we think about anxiety, it can show up as images, it can show up as a bunch of thoughts about, am I okay? Am I safe? right? It can show up physiologically. You can get upset stomachs. You can get sweating. You can get your jaw clenched, right? Some kids are actually going to lead with these physical sensations, physical descriptions, rather than saying that they're anxious. But it's a skill to label your emotions. It's actually a really valuable skill because the better you're at in terms of labeling your emotions, the more you can befriend them, the more you can use that information rather than, run from that information. So again, when anxiety shows up, it's saying, hey, you might be in danger. And so then we need to get our frontal cortex online and go, ooh, what might this danger be? Right. And that's the skill of not reacting to anxiety, but noticing it and using it as a cue, right? What in my environment is going on that I need to attend to, or do I really need to attend to it? Is a false alarm. An anxiety disorder is that your anxiety system has been co-opted and you're getting a lot of false alarms.
Okay, so anxiety itself is not uncommon in kids. I guess the real question here is that at what point does normal childhood anxiety become problematic?
It's a great question. And so one of the things to consider is that humans in general are born with different kinds of temperaments, right? Within the normal realm of human variation. Some people seek novelty and are excited and are curious to explore their worlds, right? We also have kids who are more inhibited. They are shyer, they are quieter, they have a slightly lower threshold for overwhelm, right? And they might actually need more downtime, more away time, etc. These are all not anxiety, right? These are just differences in how we are built as humans. So when anxiety enters the mix, what we would see, and it does vary quite a lot over child development, is increased fearfulness, fear of separation. We might see bigger emotional reactions, crying, sometimes even fighting and tantrums when kids are asked to face things that they fear, right? When you have younger children, they are less adept, as Jeff pointed out, it's a skill to be able to label your anxiety, right? Younger kids may not be able to label the feeling that they're having. So, and as things go on, so there are normal developmental fears that occur in childhood as well, right? So for kids who are 18 months old, it is very normal for them to have separation fears and cry when they're separated from their caregivers. When you're 16 years old, if you have intense fears about being away from a caregiver and you won't tolerate very well them being in a different room or being out of the house without you, and you're constantly seeking reassurance about that, that would suggest the nature of a disorder. So there are two criteria, really, of course, the cross of any kind of child development that would determine whether anxiety is a problem and not just a phase and a normal developmental fear. One is there intense distress that is caused to the child that seems developmentally inappropriate at the time? That's number one. And number two is, are you seeing functional impairment, or are they having difficulty functioning in home environments, in school or academic environments, and with friends?
Jeff, there are a number of anxiety disorders by definition. Can you walk us through the more common ones for kids and teens?
Yeah, so we have simple phobias. I was just looking, I did my master's thesis actually was on spider phobia. I still don't like spiders, just by the way, but developed this scale. It's, again, it can be animals, it can be blood.
Anything, yeah.
It can kind of be anything that you have an intense fear of when you're in a situation where, again, a spider shows up. You have intense anxiety. You have lots of thoughts about, am I going to be okay? You might avoid, you might escape, you might cry, you might get someone to help you get rid of the spider, right? So we have simple phobias. They tend to not be terribly impactful in most people's lives. Because, again, if you have a spider in your house, you just get, your spouse to get rid of it. If you're afraid of snakes, you don't have to go into the woods. So sometimes there isn't a lot of impairment when it comes to simple phobias. But then we have social phobia. social anxiety, so intense fears that come up when we're in social situations. Lisa and I were looking at, as people were coming into this virtual Zoom, how many people might I make a mistake in front of? How many people might I look foolish in front of? So it's anxiety, but also embarrassment. So I don't want to go into situations that I'm going to look foolish. So we start to avoid social situations. Public speaking is a great example of social anxiety. Then we have generalized anxiety disorder, and this is your typical worrier, someone who worries about the dog and they worry about the mortgage and they worry about their job and they're spending a lot of time in their head, but they're always tense and their body is feeling uncomfortable and they have a lot of GI upset, right? So worriers. But again, underscoring what Lisa's talking about in terms of functional impairment, we all worry. I'm a worrier. How much is it getting in the way of my day-to-day life? If it's not getting in the way of my day-to-day life, then I'm just a worrier. That's fine, right? Then we have post-traumatic stress disorder. So we have someone who's experienced a trauma, and in the experience of the trauma as they move forward in their life, it's kind of like that trauma is kind of following along with them, right? They're having a lot of intrusive images about it. They're avoiding cues that might bring up memories about it. They might be having flashbacks or nightmares. Let's see. Then we have obsessive compulsive disorder, where we are experiencing intrusive thoughts that aren't about us, right? They're like, oh my goodness, I'm having this weird thought about walking to a room and swearing in the middle of a classroom, right? I don't want to do that. I don't want to cause attention to myself. I don't want to act out in that way. So I have this intrusive thought, and then it's causing me a lot of distress and trying to get away from it. Now I'm engaging in behaviors we call compulsive behaviors. I'm doing things that are trying to get rid of that anxiety, get rid of that obsession. And these could be external things and these could be internal things. So they could count, they could pray, they could reassure themselves. They could ask you for reassurance as a caregiver, as a teacher.
Yep.
Lisa, did I miss any of them?
I think you got most of them. I would just add maybe health anxiety, which is and separation anxiety are two that you see in childhood. So health anxiety is a form of anxiety in which individuals might experience a sensation in their body and become extremely concerned that it's very dangerous, like or deadly. And they will ruminate about it. They will worry. They will try and figure it out. They might look on Google or WebMD. They might ask parents or go to doctor's appointments and things like that. And those are all considered avoidance behaviors, right? Because there's a worry, an experience that they've had that they're trying to solve and get some certainty around. Separation anxiety is a fear we discussed earlier. It's very normal at different ages in childhood. And when it becomes excessive, in the sense that a child won't tolerate a caregiver being away or apart from them for a significant amount of time and seek lots of reassurance about when are you going to be back, or tries to prevent the caregiver from going out, tries to know exactly where they are every minute, lots of texts and calls and things like that. So those are two other kinds of anxiety disorders. And some people consider also selective mutism as related to anxiety. It's selective mutism is a disorder in which children who can and do speak in different environments will not speak in, for example, school or to adults or anywhere outside of the home with no other impairments. It is thought to be a precursor or a correlate, something that co-occurs sometimes with social anxiety. And it also sometimes comes when kids have an issue with speech deficits. So it's not quite an anxiety disorder, but it's often related to and occurs with anxiety, especially social anxiety.
Okay, a lot to unpack there. Let me ask you a couple of questions about OCD specifically. And Jeff, not to get us into the weeds, but because there is some confusion about this occasionally, is OCD considered an anxiety disorder? And if not, why the distinction?
So the way we diagnose is to use the Diagnostic and Statistical Manual. In this country, there's also the ICD that's that's used internationally, but different groups of experts get together and look at research and try to look and see how can we categorize people based on their presentation, based on the cluster of things that they're struggling with. And so, for example, someone that has depression is going to have a different treatment plan, a different intervention than someone with an anxiety disorder, and they're going to have a different treatment plan than someone that has a psychotic disorder, right? So there's some value in being able to diagnose. So in the last version of the diagnostic manual, when it came out, they decided that through response to treatment, through looking at neurobiology, these kinds of things, that the anxiety disorders that Lisa and I mentioned, generalized anxiety disorder, phobias, kind of hung together as a group. And OCD had been in that same chapter, that same grouping. And what they found is that although anxiety is the primary experience that people report, there's a lot of guilt for some people with OCD that might be primary. There's a lot of experience of disgust that might be primary. And so it ended up being not just anxiety, but other kinds of emotions that showed up. And they found out when doing, brain imaging scans that actually OCD is located in a little bit different space than the other anxiety disorders. So it's similar to, and the kind of their argument was, it's the chapter next to. So there's anxiety disorders as a chapter, and then it's called obsessive compulsive and related disorders is the next chapter. So OCD is the primary one in that, but we now have hoarding disorder that got pulled out from under OCD. It's now its own disorder. Again, that's shown based on treatment response, what the deficits are, the neurobiology, et cetera. Then we have body dysmorphic disorders, so this preoccupation with a flaw in our appearance. We have body repetitive focus disorders. So this is trichotillomania or hair pulling, or excoriation disorder, skin picking. Tic disorders are kind of in their own camp. And again, they tend to co-occur with these other related disorders and are typically considered a related disorder of OCD. But, sometimes it's important to really get a clear diagnosis. It drives treatment. And sometimes it's important to kind of hold that lightly. It isn't the end all be all.
Lisa, when it comes to OCD and kids and teens, what are some of the more common subtypes? And we think often about kids washing their hands or checking doors, for example. Are there certain subtypes that are more prevalent than others when it comes to kids and teens?
I would say that there are certain subtypes that kids are more willing to share, but I would argue that many of these are very common, and kids, depending on their age, depending on the nature of what the concerns are with OCD, are more or less willing to share with us. So I'll go through some common ones. As you mentioned, there are contamination fears in OCD. And I just want to back up a little bit too before we go here and just say something about anxiety disorders and OCD and the relationship. The thing that is similar across anxiety and OCD is there are two components. I want to put on sort of a behavioral hat here for people so that we can really think about what are the behaviors involved in these disorders that lead to functional impairment, right? So the first, so kids experience distress, whether it's a thought, an image, we'll talk about those in a minute with OCD, the experience of anxiety, a physical feeling of anxiety as in panic disorder, etc. And when those feelings or thoughts or sensations happen, it's hard, it's aversive, kids don't like it. And so what they do is they engage in a behavior to fix it. We call that an avoidance behavior or a safety behavior. Those behaviors work because they usually bring some short-term relief. Right? So there's in OCD in kids, there's an obsession, scary thought, image in the imagination, physical sensation, a sense of incompleteness, a sense of uncertainty, a sense of need to know, a sense of doubt, right? And then kids engage in a behavior to mitigate that, to fix that. Get a short-term bump, phew, okay. Then when that thought or feeling comes back, they do it again and over and over and over and over. This kind of avoidance pattern is what causes the functional impairment. So, common things that kids avoid: contamination and OCD. Contaminant can be anything from a germ to dirt to chemicals in the environment, fluorescent lights. A contaminant can even be another person, because one form of OCD that is less talked about but is not uncommon is what we call emotional contamination. So, for example, my friend Jeff, let's say that I don't like a particular characteristic of Jeff. And so I avoid being around Jeff because if I'm near him, I might take on an unwanted characteristic. And maybe I engage in some rituals to make sure that I don't take on that characteristic. So that's one kind of OCD. Another subtype might be harm-related thoughts. So kids, and this is a tough one for kids to talk about. They're very frightened of this. This is one that is commonly misdiagnosed in emergency rooms by pediatricians, by people who are not informed well. So this is a kind of OCD in which children or adults or teens may experience the doubt that perhaps they hurt someone, or they might even have an image flash into their mind of them hurting someone or hurting themselves. This is very frightening. And so what you'll see is lots of rituals or lots of rumination trying to figure out, is this real? Is this true? You might see lots of checking. You might have lots of reassurance or asking for reassurance from caregivers and others. Did I hurt you? And the types of harms can vary from, did I offend you, to, am I going to murder you? Right? Am I going to engage in some sort of sexual harm with you? And it is so, you can imagine why it's so difficult for anybody, especially children, to talk about when they have these images or thoughts that they don't understand. And they think that they're going crazy. They're absolutely not. It's just OCD. And it's important to know that these things can go on. There are lots of other forms of OCD. Another common one is movement-based OCD, where kids might they might have an uncomfortable sensation in their body, and they might need to move their body in a certain way or engage in certain repetitive behaviors like tapping things to even them out, right? So things feel symmetrical. That's often mistaken for tic disorders. It's not a tic disorder necessarily. It's often OCD. So that's another one. There are many more. But in general, what I would say is OCD can have a pattern, right, of having a recurrent, intrusive thought that you don't want to be having over and over, right, or feeling or urge or sensation. And when that occurs, you engage in a compulsion, a compulsive behavior, or a ritual. That's the avoidance behavior, right? So anything that you see as a clinician or a teacher that involves those two pieces, it sends a flag. It sends a flag up to me. Is this OCD? Right. So there are other kinds of OCD, but maybe I'll let Jeff talk a little bit about some more. There's so many.
There's a ton of them. Scrupulosity is another one where we have your faith and spirituality being taken over by OCD. What is my relationship with God? Am I doing something blasphemous? Am I making God upset with me?
Or morality, even in kids, you see it with rule
Morality.
violation, fairness.
Exactly. There's the I'm not being careful enough. Did I turn off the stove? Did I turn off the coffee pot? Was that bump in the road a person, or was it just a bump in the road, right? Am I being careful enough? Inadvertent harm to others. I do always, when we talk about subtypes, I try to make sure we get these other two in because, again, less understood and very important. One is PANS, so pediatric autoimmune neuropsychiatric syndrome.
Mm-hmm.
And so this is when OCD as a kid or adolescent from an infection. And what happens is that your body fights the infection, but it goes haywire. And in fact, your antibodies start to attack your brain. And the part of your brain that gets attacked and inflamed is the same part of the brain that we know is implicated in OCD. So you have this overnight onset of OCD symptoms, which is not typical in traditional OCD, but it is in this infection-based. And the most common version is a kid gets a strep infection normal functioning, doing just great, and then all of a sudden tantrums and again meltdowns and
Fears, separation
control,
anxiety, all of them.
separation
Yeah.
anxiety, all that kind of stuff. The other subtype of OCD that I think is really important to talk about is perinatal OCD. So this is when a woman gets pregnant. She might develop OCD during her pregnancy. After giving birth, there's postpartum depression everyone's heard about. There's actually postpartum OCD. So again, there's something biological that's changing. And when a woman is pregnant or has had given birth, in the caretaking of the baby, it might be, I'm not being careful enough. Mothers will camp out outside the crib and make sure that the baby's still breathing. I can't do anything. I had a friend who developed postpartum OCD, and she couldn't bring her baby up and down the stairs because she kept having this intrusive image that she was going to drop the baby, right? Now, what's really interesting about this is that the father can also have perinatal OCD. So and I've worked with guys who moved out of the house because they felt like they couldn't take care of their kid because they weren't doing it right, or they were going to inadvertently harm them in some way. So it's really important to get that information out there also, because sometimes when a parent discloses these symptoms, they have their kids taken away.
That's right.
Understanding it as OCD. These are thoughts they don't want to have.
It also makes it really challenging to research. Our clinic has done some research in concert with Harvard Medical School on this, and there are such protections that we have to put in place for participants who have this form of OCD to even disclose that I might have this thought, and it makes sense because so few people know about it.
Yeah. And then my pet one, Jeff, right before we move on, is perfectionism, right? So there's a term called clinical perfectionism, which is, a perfectionist who has to do everything just the right way and nothing is good enough. And sometimes you see that in depression, sometimes you see that in OCD, and sometimes you see that in some of the other disorders. But again, it's this preoccupation with everything. This is the stereotype of what OCD is. All of my pencils have to be ordered and all of my socks have to be ordered. That isn't OCD if you like it. I like an ordered, straightened up office and house. But when you don't like it and it's stressful and it's getting in your way and it takes 3 hours to write an email that should take 10 minutes, now we're into disorder land.
There's one more I want to mention, Jeff, before both Jeffs. So many Jeffs today. And that is it. And this is a misnomer, but I do think it's important to talk about because sometimes people ask about with children, does this occur in them? And 100% it does. So it is sometimes called pure OCD, which means purely obsessional, just having lots of scary thoughts, right? That is a misnomer. There are forms of OCD. All forms of OCD have a triggering private event, thought, feeling, sensation, and a related and responsive behavior, avoidance behavior that happens. Most of those avoidance behaviors we can observe as clinicians. Some of them are what we call covert avoidance, which means we can't see them as clinicians, but the sufferer is still engaging in them. And these types of covert avoidance behaviors are called cognitive rituals. So someone, for example, a child thinks, I'll think of a specific example. If I walk past a church and I don't engage in saying, I love you, God, 3 times, I'm going to be struck dead by lightning. So you won't see this occurring, but this child will be thinking these things in their head to make sure they don't get struck by lightning, right? So it's really important to notice that even though you don't, as a clinician or a teacher or a parent, see a clear repetitive behavior that suggests avoidance, it doesn't mean one isn't going on, right? That's really important. In fact, many parents also miss their child's bids for reassurance. Am I going to be okay? Am I going to be okay? They don't recognize those as rituals. So those are really, really important.
Great job, you two, running through a lot of material there in terms of the bigger picture of what these anxiety disorders can look like. We want to talk diagnostics, we want to talk treatment, but I also want to weave in some of the questions that are coming in from audience members right now. Would you please speak to panic disorder? Does it commonly co-occur with other disorders? Either one of you can take that.
There's huge overlap with most of the disorders in the Diagnostic and Statistical Manual, up rates of about 40%. So it's uncommon to see panic without something else. A hallmark of panic disorder is that it occurs out of the blue, not in response to a specific situation. And one of the etiology for panic disorder is such that someone has a lot of what we call anxiety sensitivity or a fear of feeling anxious. Thus, they might be hypervigilant for physical sensations in their body that might trigger panic, right? And so guess what happens when you watch for physical sensations that might trigger panic? Jeff, do you want to answer that one?
Get more physical sensations.
Yeah, exactly. And then you're more likely to panic. And so that's really important. So a lot of people who have children who are anxious will tell me they have panic disorder. And no, they have really intense anxiety in response to a situation, right? It's only a panic disorder if it occurs out of the blue.
Interesting.
And it's pretty discreet, right?
Mm-hmm.
If it continues on, it's because they're doing something to perpetuate it, right?
Yeah.
And I'm glad that this got brought up because we missed panic disorder and we also agoraphobia, and those two seem to hang together quite a bit. Mm-hmm. So because I don't want to have a panic attack, I'm going to not go to the mall. Now I'm going to not go to the grocery store. Now I'm not going to drive alone. Or school. And so now we become more and more homebound. Now, if we get into big open situations, we start to get anxious and then we bring on a panic attack because of our hypervigilance of our body. And it's fun. That treatment's fun to work with people with panic disorder because you get to run in place and you get to purposely hyperventilate. We're going to expose folks to their body sensations to show them it's just your body. It's just hanging out.
Your body. Yep. And I do want to say too that in the typical population, it is not at all uncommon for people to have 1 or 2 or 3 panic episodes in their life. That's not panic disorder. Panic disorder is persistent, right, over time.
Fascinating question that came in. I'd love for one of you to tackle here. What are your thoughts on the modern age, specifically the constant amount of stimulation offered to children and teens today? Are you seeing an effect on the onset or the severity of anxiety disorders within that demographic?
Well, after the pandemic, we saw an enormous exponential rise in anxiety disorders because I think that the research is still teasing apart exactly why and exactly how. But what happened was, we had these extreme disruptions in life and the addition of all these stressors, all of these unknowns where we lived in fear for years, literally. Kids were taken out of their support systems, schools. They, learned in isolation online. They had to figure out how to make and keep friends online. For example, I have a son in college now who's 18, and I realized at his graduation, which was disrupted by a giant thunderstorm where all the lights went out, the speaker, when this happened, said, well, there's no better group to deal with this than this group who has had only 1.5 years of high school education in person because the rest was taken over by the pandemic. So I don't know about the constant stimulation and how that is at play here, but I do know that when we have these enormous contextual changes, it's a huge ask for our kids to adapt. And for kids who are more inhibited and more vulnerable to the development of anxiety disorders or OCD, we have seen an increase. And it's incredibly concerning to us in the mental health field because we recognize there are so few practitioners and treaters available who are trained in evidence-based treatments for these issues.
Yeah, in my role, Jeff, when I was at the International OCD Foundation, I got to talk with lots of different people. And I would talk with anywhere from 100 to 200 different therapists. In COVID, the first 3 years really of COVID, every single therapist, anxiety disorder specialist was full, had a wait list. If they were running a clinic like Lisa, they couldn't find enough therapists to fill the need. So there was this avalanche of seeking out mental health services during COVID, which was, you know, a symptom of what we were all experiencing, but it also gave people access to care that they might not have otherwise sought out. And in the era now of teletherapy is we've increased access. So I knew people that would drive 2 hours to one way to go to a therapy appointment. Now with teletherapy, most people are doing teletherapy full time or some hybrid. So if you're in North Dakota, you can get access to care in a way you couldn't before. So that was one of the silver linings of what happened.
And a viewer would like to know how often people, young people specifically, turn to self-harm or cutting to cope with anxiety or OCD. What should we know about self-harm and OCD?
So there are lots of reasons that people engage in self-harm behaviors. And I want to make a very clear distinction between harm OCD and self-harm behaviors, right? Harm OCD is about experiencing recurrent intrusive thoughts, fears that you might have an urge to harm, right? That are unwanted and what we call ego dystonic, which means you're having them and you do not want to engage in these behaviors, but you're scared you might, right? So self-harm behaviors occur across a number of different mental health disorders, including mood disorders, anxiety disorders, etc. And they occur and kids use them as a way of coping, as a way of expressing emotion, of feeling emotion, and a maladaptive tool for doing this. And at the heart of it, of that particular problem, is helping kids learn better and more effective ways of experiencing emotion, of modulating their emotion or regulating their emotion, expressing their emotion, getting support for around their emotion. So it is not, you would not typically, so self-harm itself is not included in diagnostic categories for anxiety disorders, right? It can co-occur as it does at about the same rates across different kinds of disorders.
Jeff, let me hit you with a question here. Are people with OCD potentially at a higher risk of creating false memories due to the repeated intrusive thoughts?
You know, I think when you are engaged in checking behavior and mental reviewing, the research is that you start to trust yourself less, right? So when you, but which is true in general with compulsive behavior, the more you do it, right? So let's go back and think about anxiety. Anxiety shows up and says you might be in danger, might, right? If you engage in the world in a way that is protecting you or avoiding or I am in danger, you reinforce that part of your brain that says you're in danger, right? So if you're going to check and check and check and check and check, you start to lose connection with the world. You start to lose connection with trusting your senses, right? So compulsive behavior, actually, we begin to live our life in our head. We begin to live our life in imagination. We don't want to live our life like it's nice to be able to say, oh, I can avoid that danger by kind of thinking about a way to get around a real danger, right? I think about that in my head, I problem solve. But it's kind of an over go-to strategy for all of us, right? We're always kind of problem solving, but it's actually worry. Well, what if this happens? And what if this happens? But now we're living our lives in our head, right? And so we stop trusting our experiences, trusting our senses. We stop trusting our world. And that is what ends up being problematic and reinforces even more avoidance.
Let's take a couple minutes to talk about the basics of OCD and anxiety disorder treatment. There are a lot of topics we can dive into more specifically regarding treatment, but kind of paint the broad picture for us, Lisa, if you would, in terms of
Sure.
the gold standard of treatment for OCD and anxiety disorder, specifically when it comes to kids and teens.
You got it. So I'm going to go back to that behavioral description of anxiety and OCD that we discussed before. When you have a private event and you remember that's thoughts, feelings, emotions, bodily sensations that you don't want to be having, you find them unpleasant or aversive, and then you engage in a behavior to fix that, which we call an avoidance behavior or safety behavior. And engagement in that kind of cycle gets you stuck, as Jeff described, in your head, where you are engaging in very rigid patterns of avoidance. And because you're doing this all the time, there is very little opportunity for you to learn anything different might be so about the world or about your ability to experience anxiety and survive it. And actually, it's not what your mind is making it out to be. So the treatments, the gold standard, and people have this term gold standard has fallen out of favor. So I'm just going to say our most robust and rigorously tested treatments for anxiety and OCD are broadly classed cognitive behavioral therapy, but very specifically, all of them involve two pieces: exposure and response prevention. Exposure means instead, when you have an unwanted or scary private event that you don't like, let's say you have a child who's afraid of potentially getting ostracized at school, so they avoid school, right? So they have this scary imagined future of the day. Oh, no one's going to like me. They're going to make fun of me. I'm going to get left out, right? So they avoid school. Exposure would be, let's practice having that thought, having those feelings that go with that thought, and going to school anyway for a short period of time and seeing what we can learn. And let's be curious about what our day might be like. Are there things that are positive? Are there things that school fun? Did somebody be nice to you? And actually, were kids not mean to you? What did you notice, right? And here's the response prevention part. So let's say said child is in school. It's okay, but they're starting to lose their nerve and they want to go to the nurse's office and call mom and dad and say, can you please come and get me? I'm sick. I'm scared. I have to go home. The response prevention part is mom and dad saying, you know what? We love you. We're so proud of you. We get how anxious you are. And you know what? We're going to let you stick it out, right? So response prevention involves blocking the avoidance behavior, right, in kids, or teaching kids to resist engaging in that avoidance behavior. So those are the two pieces of our best treatments for anxiety and OCD.
Jeff, anything you want to add to that?
Yeah, I want to go back and just elaborate on Lisa involving the family. So I am famous for saying OCD is a family affair, meaning that
Yes.
OCD gets into schools and it gets into your friendships and it gets into your family relationships, it gets into your parenting. All of a sudden, your house is being run by your kid's OCD, not by you, right? And so I think when you're watching TV and it's maybe Sopranos and you're looking at like, oh, that's what therapy looks like. It's individual, it's the identified patient, it's their personal stuff, it's confidential. We don't talk about that with anyone else. We're going to protect your confidentiality. Of course, we protect confidentiality, but when your symptoms are affecting people around you and they're doing the best thing they can, they're doing the same thing. The kid is like, I'm anxious, I want to make this go away. And you're like, you're anxious, I want to make that go away, right? So now you become part of the compulsive process. So involving family, I think, is standard of care, particularly for kids, but even for adults. I think it's really important that your system, if it's gotten pulled into your OCD symptoms, that your system is involved in your treatment actively.
Here's a key question that came in. I imagine a lot of parents would like to know: at which age or what age can we start seeing symptoms of anxiety or OCD in young people?
OCD has been documented in young people as young as 4 years old. You can certainly see anxiety and heightened inhibition. Remember, we talked about temperament, right? And maybe a proneness to anxiety in kids who are 3 or 4 years old as well. One thing that we think about, right, and look at when we are assessing whether or not this is going to be a problem or is it a problem for a child right now in early childhood is there a family history of anxiety or OCD? Because it is heritable, which means that you are more likely, you have a 1 in 2 chance if you are an anxious child, right, to have a parent, 1 in 2 chance that has an issue with anxiety or OCD. So we really look for, is there a familial pattern in that?
Jeff, a very specific question came in. I think that might serve as a good example for us to kind of walk through in terms of what parents should watch for and what they can do. So let me just go ahead and read this to you. My son has to check his room every night for monsters, but has a very specific routine. He checks the closet, behind the window shades, on top of his bunk bed, in the corners. The drawers of his dresser need to be fully closed. He has told me that he used to count to 20 when he checked the bunk bed. Now it's only once. How can I make sure this doesn't get worse or manifest elsewhere in his life? At what point should I be concerned? So using that as an example of what a parent might observe in a child, what would your guidance be?
Find out how old first.
Also true. I'll let Lisa get into the developmental, the different age groups, but a couple things you want to keep track of. One is listen to the rigidity. Listen to the have-tos. Listen to the routine. Check out how time-consuming this is. We were just talking about, like, can you do things that are going to make it worse? Maybe you go into the bedroom and you see what the routine looks like, and you encourage him to maybe not do some parts of the routine. In the way that Lisa was talking about, like, sometimes we're training parents, we're training spouses, sometimes friends, to be coaches in this process. Like, okay, so this is scary. I get it. You don't want to be going to bed and afraid. So what if we just do part of your routine? Or what if we mix up your routine? What if we don't do the drawers today? What if we just do the closet today? Right? So we're there, we're present, we're supportive, but we aren't getting pulled into it. We're just kind of, as soon as we start to change up the behavior, we're going to be in the right direction. If there's an insistence on the pattern and it's a have to, and now is getting worse and it is more time consuming, and he's getting up in the morning more and more tired. Now we want to start being a little bit more worried. But Lisa, in terms of age is really important. I want to highlight that.
Yeah. So in younger kids, that might be actually a pretty typical thing, even though it's extensive. And there's a couple of considerations that you might have as a parent. Number one is what you do about it can either tilt it towards continuing or helping your child learn sort of the skills that they need to go to bed and, not engage in some of these avoidance behaviors. So that's something. So exactly as Jeff said, and there's a name for when parents get pulled into anxiety or OCD to try and fix it for kids. It's called accommodation, right? Now, if you're a teacher and you're listening to this, you're probably thinking, well, we make accommodations in school. Not that kind of accommodation. That's something we're going to talk about in a little bit. When we talk about the interpersonal process of anxiety or OCD in families, it is that act that Jeff has described so beautifully about getting pulled into your child's rituals or routines, checking for them, reassuring them over and over and over, right? That engagement in that is a risk factor for anxiety blossoming and kids getting a sense of themselves as unable to handle those things, right? So that's one thing. The other thing I would say about this particular example is, other than considering the age of the child and how persistent this is, I would look for other kinds of fears in other areas to see if there's anything else that is similar. Now, there may not be, it may just be phobia of the dark in a kid that is a little older, and that might be not age appropriate, and it's causing impairment in bedtime, and they're tired during the day, and they're not learning in school. That's something that might merit treatment, right? So hopefully those things are helpful.
So one of my takeaways from our conversation today is that the whole landscape of anxiety disorders and OCD is rather complex.
Yes.
I want to ask you both to speak to clinicians who might be in the audience today about how they go about assessing anxiety disorders and OCD, and at what point, if at any point during that process, it makes sense for them to refer out to an anxiety specialist.
Well, there are a number of evidence-based measures that we like to use when we diagnose anxiety and OCD. We use structured clinical interviews, which are interviews that are based in research that ask questions of parents and or children, depending on the age, but typically both informants, right, about the particulars of these kinds of anxiety disorders that Jeff and I have described earlier. There are also paper and pencil measures that people can use to assess functional impairment, distress caused, and sort of types of anxiety disorders and things like that. Those are really important to get at, in the context of therapy sessions. So I can say more about specific names, or Jeff can, but I think it's important that it's not just asking a few questions, and it's also really assessing the impact of these behaviors across the board. When you would refer out, I would say I would really love to encourage all the clinicians here to know that many of us who are considered experienced in treating OCD and anxiety do consultation all the time. It is important to us to disseminate these evidence-based practices for treatment. And I would say, if you have not at least had some consultation around how to treat this, if you have not read at least one book manual on cognitive behavioral treatments for anxiety disorders in children and adolescents, or if you don't have a peer supervision group that does that, you would consider referring out. I think it's a great thing to grow your repertoire, your clinical repertoire, and your skills by taking on a case that's a little bit outside of your area with the right support so that you can gain the skills that you need to work with us.
Yeah, I want to just kind of elaborate on some of these because you see I have several soapbox issues that I this is a
Get on that soapbox, Jeff.
This is a huge one. Anxiety disorders resolve through behaving in the world, not talking about the world. And so if you're a great talk therapist, great. Please don't work with anxiety disorders, though, because unless your talking moves them into changing their behavior, their anxiety symptoms are not going to get better. So that's one piece. Now, the other piece, in the way that Lisa talked about, exposure-based treatments are extremely helpful. And you have to be well trained, because if you're not, you're going to actually do more harm than good. If you know a little bit about exposure therapy and you start applying it without support, training, supervision, consultation, you will make your client worse, because it sounds deceptively simple. If you're afraid of dogs, hang out with some dogs. If you're afraid of germs, don't wash your hands. It isn't that simple. And people jump over assessment. I can't say enough how important assessment is. In the beginning, ongoing, what is going on? Do not do an arbitrary exposure with someone. Just because they're afraid of contaminants doesn't mean they have to roll on a bathroom floor. Let's find out specifically what their concerns are, specifically what their avoidance and compulsive behaviors are, and we have to target and treat that. There is a dissemination of ERP, this model that's very manualized and very technical, and has no theory. And so it can sometimes be poorly delivered. So I can't say enough about, if you want to treat anxiety disorders, get good exposure therapy training.
Lisa, we are down to just about a minute or two left here, and I want to ask you to put out some resources that people can explore for learning more about OCD and anxiety disorders in kids and teens.
I would start with a book called, it's by Ellie Lebowitz. And it is a book for parents that describes anxiety and OCD. I believe it's called Breaking Free of OCD. And it describes the principles behind what parents can actually do just just you as parents, right, to learn more supportive communication, to learn what we call autonomy granting with children, which means encouraging them to face their fears gently, right? And to reduce their own accommodation. So that book is a very nice summary. It's pretty great. I have several books on anxiety for teens and kids that have just come out, and OCD. That's an older one. So you can certainly look at any of mine. There are plenty more. One more resource I'll mention is free. You can go online and find it. It's called Anxious Toddlers. It's a YouTube channel by a clinician, Natasha Daniels, who is a brilliant creator of content that's educational for parents and children. And you can check her out, Natasha Daniels, Anxious Toddlers, online.
Jeff, I'm going to give you the final 30 seconds here. Any final thoughts and or additional resources to pass along?
Yeah, I wanted to give a shout out to the Foundation's Anxiety in the Classroom program.
Yay.
It's free. You go in, you learn tons of stuff. There's stuff for parents, for teachers and school personnel, for kids of all ages. There are presentations that you can give to a variety of different audiences as a parent, as a teen, as a teacher. So I think that's a fantastic school-based one, but also a lot of good stuff for parents. And Lisa's books are actually quite great.
Well, this hour has flown by you too. We've touched on a number of important topics. Jeff and Lisa, thanks so much for all the great background and insights.